Welcome to Fertility and Sterility on Air, the podcast where you can stay current on the latest global research in the field of reproductive medicine. This podcast brings you an overview of this month's journal, in-depth discussion with authors, and other special features. FNS On Air is brought to you by Fertility and Sterility family of journals in conjunction with the American Society for Reproductive Medicine, and is hosted by Dr. Kurt Barnhart, Editor-in-Chief, Dr. Eve Feinberg, Editorial Editor, Dr. Micah Hill, Media Editor, and Dr. Pietro Bortoletto, Interactive Associate-in-Chief.
Hello and welcome to another episode of Fertility and Sterility on Air. We're in June 2024. This is volume 121, number 6. I'm Micah Hill, the media editor for FNS, and I'm joined today by our all-star team, Eve Feinberg, Kate Devine, and Pietro Bortoletto. Good morning, all of you.
Good morning, everyone.
It's always good to be back with this group. A month away really makes the heart grow fonder.
Yeah, best way to start the week on a Monday morning.
Absolutely. Our thoughts are with Kurt as he's on his way to Asia for the Aspire meeting. So we're with the four of us today, and we're going to dive right in because we have a lot of content and a lot of really good content to discuss in the journal for June. So we start off with the views and reviews. This month, it's a second edition from editorial editor Rick LeGros on statistics and study design. Specifically challenges that relate to study design and statistics within the space of reproductive medicine. There are 6 incredible articles that I encourage you to read. This makes 12 total articles from Rick. Just some of the highlights. When do you randomize in an RCT? There's a lot of debate about that, especially in ART trials. Dr. Linson makes the argument that it should be as close to the point of the intervention as possible, but I know that a lot of people think it should be right at the start of the cycle, but there's pros and cons to both. My fellows and I have an article about how do you handle multiple comparisons and ending trials early and looking at your data frequently during a clinical trial, which I think may be relevant today. But a lot of good articles in this second edition of this series from Rick LeGros. There's a fertile battle from editorial editor Ruben Alvaro, and this one is talking about the classic HSG versus some of the newer saline sonogram ways in which you can assess both the uterine cavity and the fallopian tubes. So I encourage you to read that. They actually couldn't get the authors to strongly feel on one side or the other, so they flipped a coin as far as which side people would be on. I'm just curious from this panel, obviously the sensitivity, specificity, positive and negative predictive values seem good, and it seems to cause patients less pain, but I've never actually done one. I'm just curious, is anyone using this clinically yet at the large centers we have represented here?
So we were just speaking about this at our recent meeting, Mike and I and another colleague of mine from SGF, and it's certainly the minority of us. That said, I'm super motivated to become proficient in it because I'm pretty convinced by the data that it's better for patients.
Big issue with it is just reimbursement. You can still get reimbursed for the sonohistogram portion of the procedure, but the actual material that you're using for injection is not covered by insurance, and that's an increased out-of-pocket expense that patients have to bear. So I think for that reason, we aren't using it at Boston IVF, and probably why most aren't using it, but it'd be cool if it were reimbursed.
Yeah, exactly. And I think you can get good assessment of tubal patency with bubbles and air.
Right. Yeah. I mean, most of the studies would suggest that in skilled hands, air and saline are basically equivalent to the foam.
So obviously a great fertile battle, and some reasons maybe why it hasn't been implemented fully into some of these large clinical practices yet. But like Kate, I'm intrigued by the data. It seems convincing, and anything we can do to reduce the pain is great. There are also 2 inklings. One is talking about the Alabama Supreme Court ruling, but from the perspective of a European in the field of reproductive medicine. And the other is from Dr. Rebar, obviously a legend in our field and longtime leader within ASRM, talking about PCOS. So I encourage you to read that. And then we have the ASRM practice opinions and ethics opinions. There's the first in a series of 4 LGBTQ transgender medicine practice committee documents that are in there. So I encourage you to read that. But enough about the front matter. We have a lot of good studies to discuss, and it's a rare month because we have 2 randomized controlled trials we're going to start off this discussion with. So, Kate, I'm going to go to you first for the seminal contribution. Tell us about the progestin protocol and what this trial looked at.
Thanks, Micah. Yeah, I was super excited to read this month's seminal contribution from Chen et al. It's entitled A Randomized Controlled Trial to Compare the Live Birth Rate of the First Frozen Embryo Transfer Following the Progestin-Primed Ovarian Stimulation Protocol versus the Antagonist Protocol in women with an anticipated high ovarian response. So the paper adds to the growing body of high-quality data suggesting that in ovarian stimulation cycles where no fresh transfer is planned, an oral progestin is likely equivalent to antagonists and obviously provides the benefits of lower cost and fewer injections. So in this open label assessor blind RCT, the authors randomized 784 women who were younger than 43 years old and had 16 or more antral follicles in a 1-to-1 randomization to undergo ovarian stimulation for their first autologous ART cycle using either an oral progestin, and the oral progestin was given as 10 milligrams daily medroxyprogesterone or 20 milligrams daily oral dydrogesterone, starting from the first day of gonadotropin versus a standard control arm of 0.25 milligrams subcutaneous ganirelix. And that was started uniformly on the 6th day of gonadotropin. And so the comparison was between these two groups in how the patients had premature ovulation prevented. They were not mixed protocols. Patients received either HMG or recombinant FSH. It was initiated at 150 to 225 international units. Those adjustments were permitted based on monitoring. Ovidrel was used for trigger unless the patient was assessed by her clinician as having a high risk of OHSS, in which case triptorelin GnRH agonist with or without low dose, they called it 2,000 units of HCG was used. And actually, the majority of the patients in the study ended up getting an agonist trigger. Women using donor eggs with communicating hydrosalpinges, with functional ovarian cysts, Mullerian anomalies, or moderate or severe endometriosis were excluded. And conventional insemination was undertaken as the default, except when morphology was less than 1%. Or the post-wash total motile sperm count on the semen sample available on the day of egg retrieval was less than 1 million. In that case, ICSI was used. A freeze-only strategy without PGT was taken in all patients. And though the authors state that good quality cleavage stage embryos were cultured to blastocyst prior to vitrification, a mixture of blastocyst and cleavage stage single embryo transfers were performed, though the cleavage stage transfers were also significantly in the minority. Authors compared live birth from the first vitrified warmed FET as the primary outcome. The FET protocol in ovulatory patients was a natural cycle FET, and oral ovulation induction with clomiphene or letrozole was used for anovulatory patients. The first FET was performed at least 2 months following stimulation and no more than 6 months post-randomization for those included in the per protocol analysis. So a priori sample size was calculated to achieve 80% power to detect a 10% difference at a 5% alpha for the primary outcome of live birth from the first FET, which resulted in a goal sample size of 356 subjects per treatment arm, and this goal was achieved in a relatively short time period over less than 2 years. So there was no difference in the primary outcome of live birth from the first FET between groups, which is a relief. And, again, in the face of this growing body of data, not a surprise. And so there was no difference in either the intention to treat or the per protocol analysis. And 84% of patients in the study arm, 83% in the control arm maintained the assigned medications and underwent at least one eligible FET to be included in the per protocol analysis. Further, the authors found no differences in any of the secondary pregnancy outcomes that were assessed. And so these included many outcomes. For pregnancy outcomes, they looked at clinical ongoing loss, multiple, and ectopic pregnancy. They also looked at cumulative live birth, but only out to 6 months post-randomization. They, of course, looked at premature ovulation, of which they said there were none, although 2 women in the study group had a premature LH surge. So I was surprised to hear that they surged but didn't ovulate. Women in the study group had a substantially and statistically significantly higher estradiol on the day of trigger. at 3,200 picograms per ml versus 2,200. And otherwise, all the cycle characteristics and outcomes, including cycle cancellation, as well as laboratory outcomes of the number of M2, 2PNs, blastocysts, birth characteristics, complications, including moderate to severe OHSS, which was notably absent, and birth defects were all similar between groups. Again, these are reassuring data. I think as a field, there's a little bit of irony in that there's so many things that we have adopted so quickly. And yet I think many of us are still using antagonists to prevent ovulation, despite a very large now body of high quality evidence to suggest that the oral medication, which has obvious benefits, is probably just as good for our patients as long as we're not doing a fresh transfer. There are a couple little quibbles I had with the study design. That said, it's certainly a very important contribution to the literature and a worthwhile, excellent seminal contribution in this month's journal. A couple things that I would have liked to see done a little differently is they used two different progestin formulations, oral progestin formulations, and didn't really go into detail as to how that broke down. Similarly, using different triggers in different patients, the mixture of cleavage and blastocyst transfer, as well as ovulatory and anovulatory patients. So it was a little bit of a heterogeneous cohort. I would have liked to see a longer follow-up for cumulative live birth if possible, although it was laudable that they looked at that at all. I was also a little bit surprised to see and would have liked more explanation as to how they wound up with 100% blastocyst conversion rate. They note that they had 3 high quality cleavage stage embryos on average, as well as 3 blastocysts frozen. You can call into question whether this is representative of the way we practice in the US, given that they did not use PGT despite doing a freeze only. And of course, it's a relatively young and good prognosis and thin population. I thought this might be a good opportunity, though, to discuss as well some characteristics of randomized controlled trial design. For one thing, we talk on this podcast and otherwise about how to report the data from RCTs, both the baseline characteristics, cycle characteristics, as well as the outcome data. And there's been a growing trend towards not reporting p-values so much as to give the confidence intervals as the most appropriate way to report these results. And there's pretty broad consensus not to report p-values in your baseline characteristics or anything really happening before randomization. So in this particular paper, they do that. Their table 1 has no p-values, but then their table 2, which is additional, cycle characteristics, many of which were present prior to their intervention, if not prior to randomization, they do report p-values, and they also do that for the outcomes. So I wanted to hear a little bit from this group as to their thoughts there. I know, Micah, in particular, this is a topic that's near and dear to you.
Yeah, Kate knows my favorite question in July or August at the first journal club is always to ask the fellows, what is a p-value? And it's always interesting, the answers that you get. But we know that a p-value is designed to test the hypothesis. And it's if there is no difference between the two groups, what is the chance that we would have found this or a greater difference? So there's no point in applying a p-value to baseline or pre-randomization or pre-intervention things, because all it does is tell you the chance that you would have found this. So whether that number is 0.98 or 0.02 doesn't matter. That's just telling you the chance you would have found it. And, randomization isn't really always going to make the two groups equal. It's just going to make any differences between the two groups random. And so I think not reporting pre-intervention, pre-randomization p-values is good. And most of the really high quality journals, you won't see those in table 1. I do hear researchers say, well, it tells us, did our randomization work? That's not what a p-value tells you. It doesn't tell you if randomization worked or not. It just tells you, it was random, any differences between the two groups. So I think that's a good point, and one that's good for the fellows to hear. And then there's also a push to just report maybe the p-values, as you said, but the confidence intervals. Because again, the p-value just tells you the chance by randomness, if the two groups aren't different, that you would have found this number or greater. So the 95% confidence interval in that point estimate, I think, is much more informative, which is the second point that you made, Kate. So I agree with you on both of those.
There's also a fun little note in Table 1, age of wife and age of husband. That probably snuck by the reviewers and the editors, but I think generally probably use less gendered language in your Table 1s is not a bad idea either.
Yeah, I saw that. I think those are excellent points about the p-value. And I think my questions are more in the clinical design. They had a 2-month washout period between the fresh cycle and the FET. And I'm just wondering, is that necessary? And if it is necessary with progesterone priming, then it may potentially be one argument against the implementation of a progesterone primed protocol. My other, just general comments, and I think we see this very frequently in studies that are done outside the US. They're comparing pregnancy rates, but their overall pregnancy rates were in the mid 30%. So for a young population with AMH levels on average of 6 and 7, you would expect a more robust response than 15 oocytes. And you would expect higher pregnancy rates in a younger population. I was also surprised that they used Clomid for an FET prep. I always think of that as a little bit of a no-no, just because of the anti-estrogenic effect of Clomid with regard to the uterine lining. So I think a lot of little gripes with you, but I agree. And I really commend the authors for doing an RCT on a topic that is very timely. And admittedly, I have not started using progesterone priming, but some of my colleagues have, and we are taking a look at our early data, and so far so good. So I think that probably this is going to become more common.
I use it as part of my clinical practice for those patients, like Kate described, that are planned cryo-alls up front, your egg freezers, your PGTA, PGTM patients. Those are patients where I think it's an incredibly evidence-based intervention, now with multiple RCTs in multiple different populations, that allows us to reduce the cost, preserve a clinical outcome, and eliminate an additional injection and make the experience a little bit more patient-friendly. I've been screaming this from the rooftops that in North America, at least, we should really be considering the use of progesterone. And I guess the final point is we should just also talk about the nomenclature. Mike and I have had this debate for forever. Progestin-primed ovarian stimulation. That just feels like we messed up the language there, right? We're not priming anything. We're giving it concurrently with stimulation. I don't know of a better term for it, and if the group has any other ideas, but it's not progesterone priming if you're giving it with stimulation, not before stimulation.
Yeah, I couldn't agree more. I think it's more like progesterone suppression because it's suppressing release of LH. And so along with that, there is some concern that has been asked about, with that depletion of LH, will an agonist trigger in a progesterone primed protocol be effective? And I, of course, geeked out a little bit and did a deep dive into the literature there. And there was an excellent Turkish study showing great response of an agonist trigger in progesterone primed cycles. And so I think that, that really well done study, and the senior author was Baris Atta, showed just really proof of concept and proof of results in that. And so I was actually most surprised when looking at hormones that the progesterone levels on the day of HCG were not significantly different between groups. And I can't wrap my head around that. If you're taking an oral progestin, why are you not having elevated levels?
The medroxyprogesterone and the dihydrogesterone are not picked up on a P4 assay.
Yeah, I was thinking that too, like an RIA, but we measure, I don't know that that's, I don't know. I actually don't know the answer to that.
Yeah, we've checked it at our fellowship at the NIH, and it doesn't get picked up by most of the immunoassays. So I think it's just that it's measuring a different part of the molecule that's not detected by at least most commercially available P4 assays.
The one thing that, if you're interested in this topic and you want to learn more from the Midwestern Reproductive Symposium meeting coming up next month, we're actually going to be discussing this topic with a live panel, and Baris Atta from Turkey is actually going to be one of our panelists zooming in from Turkey to talk about this topic and kind of go through this paper and other papers in detail.
Awesome. And I would just say to all of you out there who are boldly thinking that you're going to institute this protocol at your own center. Very supportive of that given the data, but always when you institute a protocol change at your own center, you have to do your own internal quality control, and that's what we're doing now at SGF. And as Eve said, so far so good, but you got to do your own diligence, of course.
That is a great summary and a great presentation, Kate. A really interesting protocol. Pietro, I agree with you. We misnamed it. Nothing is being primed here. And there's a consider this article from my fellows I received this weekend that I'll send to you, and we can submit that. If you've never read Consider This, that's a space for you to write articles such as, are we naming this the right thing? Should we change this treatment? So sort of opinion-based articles within Fertility and Sterility. So you can look for that upcoming. But this isn't the only RCT that we have this month. Eve, I think we're on to you, and we have something called PIEZO-ICSI versus ICSI in another RCT. Tell us about this.
Yeah, so the title of this is Improved Fertilization, Degeneration, and Embryo Quality Rates with PIEZO-ICSI compared with conventional ICSI, a sibling oocyte split multicenter trial with the first author, Deirdre Zander-Fox, and others from Australia. The objective of this study was to investigate whether PIEZO-ICSI increases the fertilization rate, decreases the oocyte degeneration rate, and increases utilization rate per oocyte compared to conventional ICSI. And I think, we've talked a lot on this podcast as to whether we are overusing ICSI and whether ICSI has more potential to cause harm than help in some situations, especially in the absence of male factor. We also have a paper today that we're going to be reviewing. And we talk a lot about innovation and how sometimes we're seeing incremental steps rather than giant leaps. And I think that this is maybe one such example of an incremental step, but spoiler alert, I think more work is needed. The word piezo is a Greek root, and it means pressure or to push. And so in ICSI, a spiked micropipette is used to penetrate the zona and the oocyte membrane. And then we aspirate the cytoplasm to facilitate membrane breakage, and then the sperm is deposited into the oocyte. ICSI has been criticized because of the forces that are used to penetrate the oocyte and break the membrane. And it's hypothesized that this can lead to deformation of the oolemma and leave the oocyte susceptible to damage. And so piezo-ICSI is a modified form of ICSI where a piezoelectric actuator is used to create a high-speed movement of a blunt injection pipette. And the fine movements allow precise micro-drilling of the zona and then smooth penetration of that blunt pipette into the cytoplasm. And a single piezo pulse, so this push pulse, facilitates breakage of the membrane, and the sperm are deposited into the cytoplasm, and there's no aspiration or agitation. And there's been previous work in both animals and human studies showing promise of this technique. So this was a randomized split, Pietro, your favorite, sibling split multicenter trial. Patients who had medical indications for ICSI and who had more than 6 M2 oocytes were included. Cycles were managed per their usual protocols, and on the day of oocyte retrieval, the eggs were split into 2 groups, conventional ICSI and piezo-ICSI. Oocytes were then randomly assigned to each arm, and extra oocytes, if there were odd numbers, were allocated to ICSI. The primary outcomes that they looked at were fertilization rates, and secondary outcomes included degeneration rate, embryo quality, embryo utilization rate, aneuploidy rate, pregnancy, and live birth rate. So in total, there were 108 patients included in the final analysis. They had an average age of 35 years, and there were 2 positive findings. So 1, the fertilization rates were better in the piezo-ICSI group compared to conventional ICSI, so 72 versus 66%. Second, the piezo-ICSI group had a higher proportion of top-graded blastocysts, but not a higher number of blastocysts. Overall, there were no differences in abnormal fertilization, aneuploidy rates, or embryo utilization. And I think probably most important was that there were no differences in clinical pregnancy rate or live birth rates between groups. Additionally, there were not differences in birth weight or congenital anomalies. So I think that's a really interesting and a very well done study. And at first, when I read it, I thought, okay, well, maybe single cycle pregnancy rates are not different, but there may be some benefit in the cumulative pregnancy rate. And the study only followed patients out for first transfer. But given the higher fertilization rate didn't lead to higher numbers of blastocysts, I actually don't think that that will be the case. I think it leads us to question whether we're spinning our wheels with this technology or whether we're onto something and further refinement of the technique is needed. Team, what do you think?
Yeah, I couldn't agree more, Eve, that more data is needed before implementing this into clinical practice. It certainly is an interesting hypothesis generating study. That said, improved fertilization is just the tip of the iceberg. And there's also, the concern over their having stopped and analyzed the data prior to achieving their full enrollment goal. And so, I think we do have to take this study as one that leads us to look for more data on this before we would implement it in clinical care.
Wanted to follow up on that point, and then I'll get back to you, Pietro. Kate, I heard you say at the conference we were at last week to a fellow during research that if you look at the data, you change the data. And in the same issue in the statistical articles from Rick LeGros that he led, we show a scenario where you're flipping a coin, but you're looking at the outcome in your trial where it's 50-50 and you're looking at it after every patient's enrolled. And if you do that in the simulation we ran, you do find significant differences at multiple times until you get to a big enough sample size that the randomness evens out. And so it was concerning to me that these authors looked at their trial and ended it early, and they didn't report it. So it's not in the paper. You have to go to their clinical trial registry, and you see that then they specifically state, we found statistical significance, so we stopped the trial. That's really not the way to do it, because most trials you probably will, by random chance, if you're looking at your data often enough, find a difference. And with this p-value that's around 0.03, if you adjust for even a single look, it's not going to be significant anymore. So a 5% difference in fertilization, is that meaningful clinically with the additional cost? But we also have to ask, is that actually real? So the second point I wanted to make, and Pietro, sorry, get back to you, is we're talking about sibling oocyte design. They're great for sort of proof of concept or validating that the intervention in the lab that we want to do works. So in this case, does the intervention improve fertilization? The problem with looking at anything on the pregnancy side of it is you don't have both arms of the study equally represented anymore, because you're just transferring a single embryo from one arm. There's only one trial I've ever seen from Richard Scott where they biopsied both embryos, put them back in, and then if a single son was born, they had DNA fingerprinting and looked in and saw which arm that baby came from. Obviously, we'd probably consider that unethical now, and Richard said that when I've talked to him, because we can't do double embryo transfer just to prove that trial design. So really, in my mind, this sort of study is an intermediate step in validating that the intervention might actually do what we think it does. Does it improve fertilization? But then you have to do a clinical trial, randomizing at a patient level to see if it actually changes patient outcomes. And with such a small difference of 5% fertilization, I'm not sure that it actually would. Pietro, back to you.
I just want to take a step back for a second, and I'm going to take my former Cornell fellow hat off. Let's talk about indication for ICSI. So if you look at this paper, 70% utilization rate for ICSI in that clinic. That's really high. I don't know that I have 70% indication for ICSI in my practice. They talk specifically about patients with male factor, patients with previously failed fertilization with conventional insemination, and patients with idiopathic infertility. But if you look down at their patient characteristics table, they have a lot of patients with tubal factor, PCOS, ovulation disorders, endometriosis. I think when you're starting off with a pretty heterogeneous group and applying a nuanced intervention like ICSI and then trying to see if PIEZO ICSI is any better, you're going to really dilute out any potential effect. So to Micah's point, it's surprising that they found something, and I think that was probably their critical failures, that they stopped early and didn't continue to look to see if that finding was true after all patients were enrolled and everyone was analyzed.
Yeah, I couldn't agree with you more, Pietro, that I really hope we start to see the pendulum swinging the other way, back towards a higher utilization of conventional insemination. It really has gotten quite out of control. And we're seeing more and more data that many of the current indications are just not good indications for ICSI. Lots of papers in the last couple of years that it's not necessary for PGTA. A shout out to our fellow at EVMS, Josh Morris, who just presented his project that hopefully we'll be seeing in publication soon, that it wasn't helpful even in frozen donor sperm at our center. So there's lots and lots of places where we can reduce intervention and really low-hanging fruit to do fewer ICSIs.
Yeah, we have aggressively tried to dial back on ICSI, frozen sperm, frozen donor sperm, PGTA, not indications for ICSI in our program. There are even some data, and I have not let go of the PGTM ICSI, but there are even some data with some of the more advanced technologies that we're using with PGTM that you probably don't need to do ICSI there either. I'm not quite ready for that, but probably will be with time. And so I think limiting ICSI to severe male factor infertility, possibly we do a lot of split ICSI for unexplained infertility or even for endometriosis. But apart from that, PCO, tubal factor, no longer doing ICSI.
This is a great segue to our next article, but I just want to put a hat on this one. It's great that the authors did an RCT. We get so few RCTs in our space that when we see them, it's very helpful. I do think looking at the data multiple times probably overestimates if a treatment effect, if it is there. And even if it is there, this requires the next step of truly validating efficacy in a clinical trial randomized at the patient level. So hopefully we don't see, as everyone's making the point, we don't see people jumping to add more PIEZO ICSI or more ICSI because of this trial, but that this is justification that we need the next step in research. So a very good study. Segues right into our next article, which is mine. It's a comparison of pregnancy and congenital malformations in the offspring of patients who undergo ICSI versus conventional IVF. This is a retrospective cohort study from first author Zhang and senior author Yang at Peking University in China. And so they looked at 10 years of cohort data that they had, 80,000 cycles. And as we're talking about ICSI, I have to commend them. 40% of their cycles are ICSI. And 60% are conventional IVF, which is probably flipped from what the typical US data is, or even more than flipped. So I have to commend them for that. Out of those 80,000 cycles, 3,200 live births. So as we've discussed, maybe a little bit lower than what we would see in the US, but still a pretty good live birth. Now, where I do have to call out their data is on their singletons versus twins, 18,000 singletons, 14,000 twins. This is the second time in a week I've said this in a meeting or in a podcast, but Kate Devine's the chair of SART Quality Assurance. And if you had 44% twins, Pietro's also on that committee, you would certainly be hearing from them. And that's not the standards that we expect in the US or from SART, where we would hope for less than 5% twins. So that's the backdrop to this study. They did GEE models, which is good because they can adjust for confounders and account for patients who are in the data set more than once when you have 10 years worth of data. They did have some baseline differences, which you might expect between the two groups. The ICSI patients tended to be younger. Both the women and the men, or the males and the females, were younger. They had a longer duration of infertility, and they were almost twice as likely to have primary infertility. I think this just is telling us that there's probably significant male factor going on, which would be significant with all four of those differences. So they did adjust for that and three other indications in their data with their GEE models. So what did they find? There were similar levels of congenital anomalies in both groups, 5.4% with conventional IVF, 5.7% with ICSI. That confidence interval definitely crosses one and is pretty broad and really doesn't hint to any differences. They looked at 12 different anomaly types, so breaking it down by anomalies. Obviously, when you do this, you're starting to add a risk of a type 1 error because you're doing multiple comparisons. But even with that, they didn't find any difference as they broke down the types of congenital anomalies. And just by random chance, with type 1 error, there would have been a 46% chance of at least one of those being significant, but there wasn't. They broke it down into other complications of OB outcomes, overall performing about 25 comparisons. So now we're at about a 75% chance that something's going to be significant. And of course, one thing was, which is that ICSI was associated with a decreased percentage of male offspring. So that could be due to random chance, but also that's been reported in at least a couple of other studies. So there could be something about the sperm that we select that selects for female sperm over male sperm. That's certainly a possibility. Or because of the multiple comparisons, it could be due to random chance. For fellows out there, I would read their limitations section. They were thoughtful. They talk about things like collider bias, which we don't often see. So obviously we know that confounders are things that are associated directionally with both the outcome and the exposure. A collider, on the other hand, is associated with both, but we think that the outcome and the exposure are causing that confounder. And so you don't want to adjust for colliders. And so that's what they talk about. So I like it when authors are critical of their data and write a good limitations section. It tells me that they really looked at it thoughtfully. So overall, as we're talking about, all four of us feel like we need to decrease ICSI use. This is a reassuring study. 80,000 cycles in a country that does a lot less ICSI than we tend to do in the US, but showing that ICSI was not associated with congenital anomalies, and specifically not even with the reproductive tract abnormalities that some other studies have shown an increase in the offspring having. So reassuring data. I'm curious what the three of you thought about this paper.
Yeah, I think my favorite part was that they used an infertile comparison group. They compared ICSI to IVF, and I think that that's really important. And I think the fact that it doesn't show an increase probably speaks more to the fact that their comparison group was appropriate than comparing to a population of normally fertile individuals. And we've seen that for all comers who have infertility, we see a slightly higher congenital anomaly rate. We quote 2 to 3% in the general population. This study showed 5 versus 5, which is slightly higher. And so I've seen this in so many studies that if you have a fertile comparison group, then you're going to perhaps inappropriately ascribe an increase to the technology as opposed to the underlying risk factors.
Micah, what do you think about the sex distribution in Table 3? So conventional INSEM, you had 64% male, 35% female, and then for ICSI, it was 55 male, 44 female. Those both seem pretty lopsided to me. Is that what you see in your practice? I think, to me, it seems a lot closer to 50-50, but
I agree. And when I was a fellow, we published one study on sex distribution, and it was more like 51-52 versus 48-49. And I think that's more in the realm of what prior literature has shown. This gets into maybe the bias in the patient population. Is there sex selection happening that's going on in China? That's certainly a possibility that's what ART is being used for. And so I would take that with sort of a grain of salt. All right, so we are staying in the ART area of the journal, and Pietro, we're coming to you. This is very specific. So we know that these ultrasound machines can sort of scan through and do 3D automated volumetric measurements of follicle size, 0.56 centimeters cubed. Is this the right size at which we should be triggering? Tell us about it.
Man, I love a paper like this, a paper that you read the title and you're like, I'm not really sure what this is about. Let me read further. So, Micah, you got it exactly right. The paper has a great title. Follicular volume of 0.56 centimeters cubed at trigger is the cutoff to predict oocyte maturity, a starting point for novel volume-based triggering criteria. This paper comes out of Tenerife in Spain, first author Adela Rodriguez Fuentes and senior author Angela Palumbo. So when you hear 3D ultrasound, you hopefully think Müllerian anomaly evaluation. It's the mainstay of evaluation of Müllerian anomalies along with MRI. We, however, in just general fertility and kind of cycle management, we're using 2D ultrasound as our mainstay. And most of our GYN ultrasounds needs are specifically during follicular monitoring. The classical teaching is that we trigger with at least 2 lead follicles with an average diameter of 16 to 18 millimeters. However, this new method using volume could potentially upend that or further inform that. So what's this new technology? It's not new. In 2008, we actually had the introduction of this sonography-based automated volume count, or sono-AVC. And since that time, we've actually had multiple studies that have been done to compare 2D ultrasound versus sono-AVC to guide follicular monitoring. So far, there's been no demonstrable difference in the number of mature follicles retrieved or pregnancy rates. However, there have been higher rates of reproducibility across sonographers using the sono-AVC method and a significant time savings with sono-AVC. But one thing that's been missing in these studies was really a robust effort at determining the volumetric cutoff associated with maturity to really optimize 3D ultrasound's utility in follicular monitoring. This, of course, is tricky to do because, as you can imagine, you have to make sure you're measuring the same follicle at the time of trigger and then assessing that same follicle and specifically the egg that came out from that follicle at the time of retrieval. These authors did exactly that. They organized a prospective study from August 2019 to July 2022 in Spain of women undergoing antagonist cycles receiving either a dual Lupron 4 milligram and 10,000 HCG trigger or Lupron-only trigger. The date of the trigger was decided on based on the center's protocol, which in this case were follicles with a volume of 0.7 centimeters cubed, and at least 2 follicles with a volume of greater than 2 centimeters cubed. And in case you're wondering, the formula for the volume of a sphere is 4/3 pi times radius cubed. I had to Google that. I can't imagine anyone had that off the top of their mind, but that's the formula when we're kind of working backwards. So the volumes of the follicles were measured on the day of trigger and again on the day of retrieval in the operating room. And in the operating room, each follicle that was drained was visually associated with a previously recorded volume, and each follicle was drained per their routine technique. So what this means is patients who had a handful of follicles, they're like, oh yeah, this is the one that's all the way out on the left. This is the one that's all the way on the right. This is the one that we saw at the time of trigger. You agree it's that one? Yep. All right, go ahead and drain it. And let's mark that as follicle number 1. So tricky to do with high follicle counts, less tricky to do with more modest counts. And that's exactly what these patients had. In total, they were able to enroll 53 women who had 206 follicles retrieved. Mean age was 39. These were young, thin women with BMIs of 23, and the mean number of follicles retrieved was 4, standard deviation of 2. So anywhere from 1 to 9 follicles being retrieved, a little more manageable to be able to associate follicle with egg. So in the weeds of the article, there was mention that 5 follicles were ovulated prematurely and 48 of them were empty follicles. I'm smirking here for those who can't see my face. We'll talk about empty follicles a little bit later. But in total, 82% of the follicles retrieved were mature. And when an ROC curve was generated, the area under the curve was 0.73, the 95% confidence interval that did not cross 0. A volume of 0.56 centimeters cubed had a sensitivity of 85% and a specificity of 64% for predicted oocyte maturity. This was the point with the highest Youden index. And if you're not familiar with the Youden index, it's a summary measure of the receiver operating curve, or the ROC curve, that measures the effectiveness of a diagnostic marker and permits the selection of an optimal threshold value, or cutoff point for that specific thing of interest. So said plainly, this study indicates that there's a 73% probability that the model will distinguish between a follicle that will contain a mature oocyte and one that will not, being that cutoff point with the highest cumulative sensitivity and specificity of 0.56 centimeters cubed. So one interesting postscript here. 5 of those prematurely ovulated follicles were measured, and their volumes ranged anywhere from 2 to 7 centimeters cubed. Previous studies on this topic had asserted that a volume of around 1 centimeter cubed was the threshold for maturity. And if you're working backwards, 2 centimeters cubed in volume is around 39 millimeters in size. That's a really big follicle size. So they were sometimes having some really, really big follicles with some really, really normal sized follicles. But that's, I guess, not the point of the article. So how does this article fit into your practice? Most of us have a 3D ultrasound probe in our office. You probably have it used for your saline sonograms, for your occasional septum, not septum patients. I think the 3D ultrasound is really underutilized in our management of fertility patients. It's a great diagnostic tool, but I think there's a huge opportunity for us to find avenues for it in our clinical practice. And really the one that stands out the most to me is just the efficiency, the time savings associated with it. So 2D ultrasound measurement of patients with 10, 15, 20 follicles, time consuming. If I can place a 3D ultrasound probe in the vagina, collect the 3D volume of the left ovary, of the right ovary, and then have computers analyze the follicle number and the follicle size for me, that saves the patient the manipulation of the ultrasound probe, has the potential, I think, of giving me more accurate, reliable information. But all that needs to get proven prospectively, of course. But I'm kind of bullish on the use of 3D ultrasound. The rate limiting step is that the probe itself is expensive. A single 3D ultrasound probe can be a couple $1,000s, not to mention the machine that supports 3D capability. So I think those are 2 big limiting factors for wider utilization. I'll turn it over to you guys. Are we ready to start using 3D volumes for follicles? Does anyone have any experience with that? I know there's a couple of companies in the US that are commercializing this technology.
Yeah, I think it's coming. I mean, we certainly have plans to implement it on a wider scale and have been using 3D follicle and automated follicle measurement in a couple of limited sites. I think in addition to essentially making the patient's monitoring visit a lot shorter, which helps the patient and helps the efficiency of the clinic, there's also something to be said for the standardization and the inter-observer variability that we see. I mean, I think most of us know who in our clinic measures big versus measures small, and so on and so forth. And so once it's automated measuring, of course, we have to acclimate ourselves to and normalize that to our typical clinical gestalt of when to trigger, since I'm not yet ready to jump to 0.56 centimeters cubed. That said, I do think that it's something that's going to make our clinics run more efficiently in the decade to come.
Yeah, and I think that the ultrasound techs are expensive, like hourly rates are expensive. And so I think that investing in a more expensive probe and program, you may ultimately save time and overtime in looking at that. You may also, this is going to be an unpopular comment, but it may allow you to use less highly trained individuals for ultrasound. If it's simply putting the probe in and the machine is doing the hard work in terms of volumetric measurements and calculations, then do you need a highly trained ultrasound tech for morning monitoring? And that may be an opportunity for a medical assistant or somebody who isn't quite as proficient with ultrasound, and then allowing us to use our ultrasonographers for Müllerian anomaly diagnosis or other things. And so I think that if we can get the technology to a point where it proves efficiency and shows comparable accuracy, if not better accuracy, then I think that it has the potential to allow our practices to run more efficiently and scale up, as we talk a lot about.
And I think the 3D volume technology is the underpinnings of home monitoring for ultrasound. So there are a couple of companies that are working on this. In full disclosure, I'm a medical advisor for one of them, but a 3D volume ultrasound is how you collect the information at home with exactly how we've said, with a non-skilled operator, to be able to standardize the collection of data and have it transmitted and analyzed remotely.
Yeah, which I then think, Pietro, gets back to the cost. Like, that's great if the probes are cheap and you can, one patient can have it for 10 days for their stim. But if the probes are expensive and you need to use one to do 1,000 scans in that same 10-day time frame, then obviously it's not cost effective. So I agree, though, that could be the holy grail. I pulled out the calculator like you were talking about because I didn't remember the formula either. 0.56 centimeters squared is only, if it's a perfect sphere, is only 10 millimeters by 10 by 10. As far as the diameter. So relatively small, but I think as Kate was saying, we're used to measuring in single greatest plane or the average of a plane. Like, each practice has its own thing. So when you implement something that's new and different, there's going to be that adjustment period while you acclimate yourself to what these new numbers even mean. On the flip side, the 2 to 3 centimeters squared is a 34 by 30 to 38 millimeter follicle. So it's huge on that side. So just interesting numbers. So we're sticking within the field of ART, and Kate, I know you're an expert on the luteal phase. So talk to us about midluteal serum estradiol and FET cycles.
And we're also sticking on the theme of the Youden index. So everyone's getting an education in assessing thresholds vis-a-vis the ROC curve today. So yeah, midluteal serum estradiol levels are associated with live birth rates in hormone replacement therapy, frozen embryo transfer cycles, a cohort study. So this is a secondary analysis of an interventional prospective study evaluating the efficacy of supplementing vaginal progesterone with rectal progesterone in patients with a serum concentration of progesterone less than 11 nanograms per milliliter on the day of transfer in hormone-replaced frozen embryo transfer cycles. And so first author is Dr. Alsberg and her colleagues out of Denmark, including senior author Dr. Peter Humaydin, did this secondary analysis to then look in the same population at whether serum estradiol concentrations on the day of transfer were associated with outcomes. So 412 patients who had an available serum estradiol concentration on the day of a single PGT untested. So PGT-A is actually not legal in Denmark at present. So it's a group of untested vitrified warmed blastocyst transfers. And so patients received 6 milligrams of oral 17 beta estradiol each evening. and 400 milligrams of per vagina micronized progesterone twice daily once lining criteria were met. And serum concentrations on the day of the transfer were collected 9 to 14 hours post the estradiol dose. So again, I know there's so many protocols out there for hormone replaced frozen embryo transfer. We dose our estrase, which is same formulation, 17 beta estradiol, 3 times a day, 2 milligrams 3 times a day, as opposed to 6 milligrams once a day. And I think that may actually be relevant, but it is laudable that the authors did standardize the timing of collecting the serum. So relatively standardized, 9 to 14 hours. So patients with endometria less than 7 millimeters were excluded from the analysis, and they evaluated the association between serum estradiol concentration and ongoing pregnancy to establish whether there was a threshold range. And so what they found was a nonlinear or bimodal association with ongoing pregnancy, again, using Youdin index. And Pietro explained that so well that, I don't have to. However, they actually, to my read, don't report the actual level of the Youdin index, again, with 1 being optimal and 0 being a test that should not be used. They just give us the range. And so the range that they established was a serum estradiol concentration of 292 to 409 picograms per ml on the day of transfer. And they did do an adjusted analysis. They adjusted for serum progesterone concentration, BMI, age at retrieval, day of vitrification, and morphology, all totally appropriate potential covariates. And they showed a statistically significant reduction in live birth of about 20% when the estradiol concentration was lower than 292 picograms per ml, and a reduction of 30% when it was higher than 409. So I found this extremely interesting. Most of the data in the literature, including our own internal analyses at my center, have not found such an association with the serum estradiol concentration. So I was surprised, and I think had a healthy degree of skepticism for this finding. A couple things about the study that I think might be able to explain it, other than that there is actually some very precise sweet spot for serum estradiol concentration. And I'm interested to hear what the three of you think as well. So importantly, only 25% of the patients had estradiol concentrations that fell into this optimal range. So that's only 100 patients. So it's not a particularly big sample to be able to evaluate this. The other thing was that they had an extremely high live birth rate in those patients. So basically, among the patients who had the optimal range, they had, almost a 60% live birth rate, which is really quite remarkable in PGTA untested blastocyst transfer. The other piece of this is this once daily estradiol dosing. I did a little bit of digging onto the pharmacokinetics of estradiol, and it's got about a 12-hour half-life. And so you wonder whether they're having some significant fluctuations. We don't get a report of the estradiol concentration at progesterone start, which is when we typically measure it. So we may be thinking about it very differently from the day of transfer. But I wonder a little bit about whether, they said that it was 9 to 14 hours post-estradiol dose. I wonder if what's actually varying here is the duration of time within that window from the last estradiol dose, which also almost certainly varies with the duration of progesterone that the patients received, which, we do think has a pretty significant implication for probability of success. So I think hypothesis generating, it's not the first recent study looking at this, and it's not the first positive study looking at this. I just would be pretty surprised if we needed to be focusing on this to this degree of precision. What do you guys think?
I have the exact same thoughts about the administration of estrogen. I mean, I'm not aware of any programs that do once daily dosing. Like most everyone I know does 3 times daily dosing or even 4 times daily dosing. So I suspect that they're seeing some of the pharmacokinetic shifts and changes with the single day dosing. And I agree for that protocol, it may be important to monitor levels, but I would also argue that, look at it, repeat the study in a program that does 3 times daily dosing and see whether or not we see differences. And so this might actually be something that I look at in our program. I'm kind of curious at this point to see whether or not we see differences. I will say in our young patients, our non-PGT success rates are very similar to our PGT success rates. And so I wasn't at all surprised by that. And I think it's the argument why PGT for donor egg and PGT for patients under 35 is really not warranted, because the success rates are truly excellent. I think this was intriguing, but it's so far off from what we do in our program that I'm not sure how to quite extrapolate it without starting a whole new research project to look at it.
I also just think we're going to be talking less and less about hormone replacement cycles. I think as the data regarding safety matures, hopefully in the direction that we all think it will mature, and I'm talking about the NAPRO study, I think we're going to be seeing just less of an indication for the use of that cycle type. And I'll tell you, at least locally in Boston, I have patients come to me specifically with the frozen embryo transfer type in mind, which I think is a kind of a humbling experience for patients who have done their own homework and they've read a little bit about pros and cons of one versus the other. And if they're the good candidate for it, I'm a big believer in it. So I think the indications for hormone replacement cycles will continue to wane, and further research into this area, I think, will hopefully head in that direction as well.
Yeah, just don't use Clomid.
Don't use Clomid.
And things are certainly trending in the direction of the corpus luteum. The next step is for us to grapple as centers with how do we accommodate these less scheduled cycles, and are there ways that we can perhaps organize things a bit for the purposes of staffing and quality control. And then circling back to what you were saying, Eve, also not the topic of this paper, but of PGTA utilization in young patients, I agree. And also there's quite an ambitious clinical trial that is currently enrolling in Scandinavia with some of these same authors, I think, participating in that. So I'm looking forward to seeing that. It's the type of validation of PGTA that we probably should have done from the beginning.
I think we would all agree that there's an estradiol floor that you have to be over to induce progesterone receptor expression in the endometrium to have a successful pregnancy. I agree with Kate that the ceiling of 400, this range of 300, 290 to 400 probably isn't physiologic. And as Kate said, we've looked at our data, and even when we use delestrase, where estradiol often gets 1,000, 2,000, very high levels, we saw very good outcomes with those patients. So I am skeptical of that finding as well. But interesting data, and like you say, hypothesis generating. We have 2 more articles as we round towards the end here. And Eve, we don't often have case reports in fertility and sterility, but we do this month. Tell us about the case report and what did we learn from it?
This is really interesting. The title is First Pregnancy and Live Birth from Ex Vivo Retrieved M2 oocytes from a woman with bilateral ovarian carcinoma. And it's a case report from Brazil. This case describes the case of a 34-year-old G0 with bilateral 9-centimeter ovarian masses that were multiloculated with solid components and papillary projections that were highly suspicious for malignancy. CA-125 was 978. Patient's young, she had a strong desire for fertility preservation, but given the size of her masses and the risk of peritoneal seeding, the patient was counseled regarding an ex vivo oocyte retrieval. So she was started on FSH injections for stimulation. Shots were continued for 13 days until estradiol trigger was administered. Surgery was planned so that the oophorectomized specimen was in the hands of the oocyte retrieval team 36 hours after trigger. They do have some pictures of this in the article, so I encourage everybody to look at that. Frozen section was, in fact, performed. It showed high-grade serous ovarian carcinoma, and the ex vivo oocyte retrieval was performed in the operating room. Follicle aspiration was performed using a linear probe, like the same that we use for an abdominal ultrasound, with a single lumen 17-gauge needle in a closed system connected to tubes, similar to how we do a transvaginal ultrasound. 21 follicles were aspirated, which yielded 13 oocytes, and 12 were matured and vitrified. Patient had optimal cytoreduction. She completed 6 cycles of carbo and paclitaxel and maintenance chemo with a PARP inhibitor. 17 months after surgery, she presented with her sister as the gestational carrier and used donor sperm. Oocyte warming in ICSI led to 9 fertilized oocytes. 2 day 3 embryos were transferred, and a singleton live birth of a healthy baby ensued. Patient is alive and well. It's still early. It's only 30 months after surgery, but she's doing well, and they had a baby. So I think this is incredible. We take care of a lot of complex cancers in our institution and complex ovarian cancers. And so this is really food for thought on, could we be thinking about this a little bit differently? They literally held the ovary in their hand and retrieved it ex vivo. So super cool, a lot of coordination. I think amazing that this occurred.
Did an ex vivo retrieval in fellowship at Cornell, and I'll tell you that it is surprisingly tricky because you don't have the feedback of the ultrasound telling you when you've collapsed the follicle. You can see the superficial ones on the cortex pretty easily. The ones that are just a little bit deeper, you're a little blind, so you think you're in something, you're not sure if you're in something. I often think that there's probably a role for ultrasound application, just like an abdominal retrieval at the time of an ex vivo retrieval, to increase that capture number.
No, they did. They used ultrasound. So they
good.
Put,
we didn't do that. That seems like a great improvement, because I was going to say the retrieval rate's higher than ours was.
It looked like they put some sort of a towel over the ovary with some gel on top of that, and then used the abdominal probe with the 17 gauge needle and went follicle by follicle to collapse each one of the follicles.
That is amazing.
Yeah, look at the picture. It's very cool.
We have one more article, but this is just a reminder that FNS does accept case reports when they're exceptional like this one, and certainly FNS Reports does, and we have FNS video articles, which often have great case reports of really cool surgical techniques, which you should check out. So Pietro, tell us about adenomyosis, and for those who aren't in a hospital operating regularly, NSQIPS data.
Oh, yeah. Thanks, Micah. This is rounding out the articles for the month today. This is a paper entitled Associations Between Race and Ethnicity and Perioperative Outcomes Among Women Undergoing Hysterectomy for Adenomyosis. First author, Renan Meyer, and senior authors Kelly Wright and Matt Seedoff from Cedars-Sinai. Prevalence of adeno is tough to estimate, right? Hysterectomy is the only definitive way to diagnose it, so estimates are from 80 to 70%. But transvaginal ultrasound and MRI are actually highly sensitive and specific for diagnosing adeno, not definitive. And the things that we commonly see are that asymmetrical thickening. We see the increased heterogeneity within the myometrium, cysts, islands, linear striations, and ultimately the irregularity of the junctional zone. But for a lot of our patients who are done with childbearing and develop adenomyosis and are symptomatic, a lot of them will undergo hysterectomy for definitive management. However, we know that with any surgical intervention, there are big time disparities that exist, particularly with minority women undergoing these major surgeries. And of course, there is essentially no data for adenomyosis and these racial disparities. So to tackle this, the authors use NSQIP, the American College of Surgeons National Surgical Quality Improvement Program data, which is a really large, really comprehensive database of around 700 hospitals that are prospectively collecting 150 variables per patient that range from preoperative risk factors, intraoperative variables, and then 30-day postoperative morbidity and mortality data. These authors looked at patients undergoing laparotomy or laparoscopy for a diagnosis of adenomyosis, and the primary outcome was the rate of major postoperative complications using race and ethnicity. Secondary outcome was the proportion that underwent laparotomy versus laparoscopy, because we know that there also are disparities in route of surgical procedures. In total, almost 13,000 women were included in the study. 70% of them were non-Hispanic white. 12% of them were Hispanic, 10% Black or African American, 5% Asian. The major complication rate was 3.1%, and it ranged from as low as 2.1% amongst Native Hawaiian or Pacific Islander women and as high as 5% for non-Hispanic Black women. And the most common major complication were organ space surgical site infections, so essentially everything that's not skin. And the reoperation rate was the second most common major complication. Both of these occurred around 1.5% of the time. When the data was crunched in their multivariable logistic regression, the factors that were ultimately associated with major complications were being non-Hispanic Black. It was associated with a 54% increase odds of major complications, along with chronic hypertension, ASA classification 3 or 4, and also the use of laparotomy. And finally, with regard to their secondary outcome, laparotomies were much more common among minority women. The rate of laparotomy in non-Hispanic white women was 11%, but went as high as 33% in Native Hawaiian or Pacific Islanders. And this is, of course, after logistic regression controlled for patient-level variables. So if you're thinking, what does one do with this study? Well, I think it fundamentally supports what we all felt but hadn't been able to prove yet for this specific disease, that there are disparities in outcomes for patients undergoing major surgery. And that in and of itself, I think, is a helpful part of the data. But for those who I think spending time in the operating room doing majors, I think it really makes us, it at least gave me some pause to kind of check myself and make sure that this is the most optimal route for this patient. And I think part of what we do as surgeons is we kind of contribute to disparities because we have a technique that we like operating on and we have a skill set that we have. This made me think that maybe I should be getting second or third opinion consults with some of my MIGS colleagues who may be able to tackle some of these bigger uteri that I might offer a laparotomy for. That may be a way to kind of check myself before I wreck myself, to use a nice line. But I think let this data wash over you, know that these disparities exist. And if you're spending time in the operating room, check in with yourself and with your patients to make sure you're choosing the most optimal, safest route to help bend this curve.
Yeah, it's yet another wake-up call about the importance of disparities research and how little we know about the differences among populations. So I certainly applaud these authors for this work.
Great. Wisdom from Pietro and Ice Cube. Check yourself before you wreck yourself. So
was it Ice Cube? I was wondering where it was from.
Yeah. I had to Google it real quick, but yeah, it was. Just like the formula for the 3-dimensional volume of a follicle. So thank you to all our listeners. This is just a reminder. Please like and subscribe to FNS On Air wherever you get your podcasts from. We also have FNS Unplugged and FNS Seminal Article each month. Before we talk to you again in July, we'll have a Journal Club Live from Aspire from Kurt Barnhart on clinical trials and PGT. We'll have Pietro live from MRSI, as he talked about, on the progestin protocol, not progestin priming, the progestin protocol for IVF. And we'll be live from ESHRA for an air episode of the Best of ESHRA. So we look forward to seeing you then. Eve, Kate, and Pietro, as always, it was wonderful to talk about the amazing medical literature and FNS this month with you.
Thanks so much, and so good to see everyone. See you all next month.
Check out this great issue. It's one of the best.
This concludes our episode of Fertility and Sterility on Air, brought to you by Fertility and Sterility in conjunction with the American Society for Reproductive Medicine. This podcast is produced by Dr. Molly Cornfield and Dr. Adriana Wong. This podcast was developed by Fertility and Sterility and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While the podcast reflects the views of the authors and the hosts, it is not intended to be the only approved standard of practice or to direct an exclusive course of treatment. The opinions expressed are those of the discussants and do not reflect Fertility and Sterility or the American Society for Reproductive Medicine.